Welcome everybody. My name is Sven Hosford. I am the publisher of a new magazine called Dispense Magazine, which hopefully you saw on your way into the expo floor. And I've been the media director at the Pennsylvania Medical Cannabis Society for about 2.5 years, and learned a whole bunch about the cannabis industry. Before that, I was a publisher of holistic health magazines in the Pittsburgh area. So I have about 20 years of experience with holistic health, which is why you may have noticed that some of the topics we'll be discussing are a little bit outside what you would normally find at a cannabis conference. So before we get started, I want to introduce our panel. We've got a great panel for you today. First, we have Dr. Randy Barrett. He's an anesthesiologist and pain management specialist, and I printed this too small, with more than 25 years experience in treating pain, acute pain, and cancer pain in Western Pennsylvania. It's up to you to figure out which one is Randy here. We have Amy Fiala, and she has 10 years of nursing experience, primarily in emergency nursing in hospitals throughout Western Pennsylvania, and she's also worked as a resource RN for emergency departments, developing nursing policies and procedures and education for emergency nursing. And Amy's there in a pink sweater. We have Mandy Baptiste. She is a board-certified holistic health and nutritional practitioner. She's an energy intuitive healer and is the proprietor of Holistic Health with Mandy in Lawrenceville. She works a lot with CBDs, and I can tell you from personal experience, she is one heck of a good healer. Mandy with an I, and she's in the red down there. Then we have Jocelyn Johnson, and she is an ordained shamanic healing minister and an adept energy healer, and she is based here in Pittsburgh and extremely skilled in healing emotional pain. And I can say that from personal experience too. Thank you, Jocelyn.
You're welcome.
So how this topic was born, why we're doing this particular topic this way, I wrote a series of articles for Whirl magazine. It's a local magazine here in Pittsburgh. And I interviewed 3 mothers, and I was struck by the similarities in their stories. And the similarities were mostly that in the role of the physician in getting them hooked and then not being able to get them off of their opiates. Dealing with the dope sick, which anybody who has any experience with opiates knows what the dope sick is. We'll talk about that a little bit. And then their discovery on their own of some holistic tools that were able to help them get off the opiates and stay off the opiates. So that's kind of the parameters. If anytime you have any questions, just stick your hand up and we'll try to get to you. I've got a pretty good list of questions here, which we probably won't get all the way through. But this is kind of the way we'll flow it today. So we'll start on the medical side of things, the role of the physician in creating addiction. And we've all heard the medical stories on TV, and we all understand that the doctors are prescribing these things, and sometimes they may or may not have the patient's best interest at heart. So we're gonna grill our resident physician here. Dr. Barrett, can you tell us what are the current guidelines for opiate prescribing and prescriptions?
Well, currently the guidelines have been a moving target. I think over the last 5 years, as the epidemic has come to the forefront of healthcare and the cost of it, the societal burden. But currently, the change has lowered the current, what we call in traditional pain practices and chronic medicine management, they've lowered the morphine milliequivalents per day. When we started out in what they called the decade of pain around 2000, for instance, there was really no defined ceiling effect or ceiling dose. There was no, too high of a dose that was relevant to the opiates in the classical sense. over that current, that 10-year span, we start to unravel and unmask problems that we didn't really see, because the original literature was really extrapolated from the cancer literature for cancer-related pain, and they tried to apply that to non-cancer pain, and that's where we got off the beaten course. And so as we unraveled some of the problems that we've defined relevant to the opiates, which are multifaceted, I'm not going to get into it now, but the dosing has decreased, and now there's a moving target downward. Here several years back, probably 5-6 years ago, they started defining it as 120 milligrams of morphine milliequivalents per day. Now they've come down to 100, and some society, depending on what society you define as the top end dose, it's anywhere from 60 to 80 morphine milliequivalents per day is the current guideline towards those, and that would include the milliequivalents or morphine milliequivalents to fentanyls and the morphine and oxymorphone, hydromorphone, known as Dilaudid, and Vicodins and oxycodones, which was OxyContin. So the top end limit has come down significantly in that sense.
This happened just recently, like in the last couple of years?
In the last couple of years, American Academy of Pain and American Medical Association and multiple different societies have really defined and come down, and it continues to come down. And even currently in our practice, I think we see there's a significant pushback from the insurance carriers to what level they will actually accept is on an individual variant basis, whether it be Highmark, UPMC, or Aetna, or at least in our region here. They really are being more aggressive in defining what they will actually allot for their patients, which is redefining that high-end ceiling effect for patient care.
Do you think that's a good role for the insurance companies to be involved in, or should that be more for the doctor's decisions?
That's a difficult question to answer in some aspects. I think there's good and bad to that, if I could define that. The good is that it's helping raise, I think, awareness to some of the physicians who were not educated to the problems of high-dose opiates, and knowing where problems begin and end, so to speak. But at the same time, it does deny in the appropriate selected individual, which there are very few indications for what we call high-dose opiate management in a chronic setting. So for that few select group, it creates an access problem. So there's good and bad to the redefining of that high ceiling dosage.
Do you find that the cancer pain is different to treat than other kinds of pain?
Yes and no. To define that, cancer pain, if we think traditionally in the traditional terms of cancer pain, we think of it as a terminal diagnosis, but which makes it a little bit easier to define the roles and the definition and utilization of medicines and multi-specialties and other interventions. But when, all too often, likewise, and this is where some of that original literature was extrapolated from, is cancer is not a terminal diagnosis, and it results sometimes the treatments that are rendered for cancer pain with the chemotherapy agents results in unmasking of chronic conditions, whether it be neuropathies or joint pain or joint problems or injuries to subsequent tissues around from surgery or neuroablative procedures. So then it becomes more of a chronic management, but it entails both nociceptive and neuropathic pathways of a traditional track that we speak on in pain management. So cancer pain can be, in many aspects, dissimilar, but it can be similar to chronic pain of a non-malignant nature as well.
Okay.
If I can.
In the article, I was able to interview Dr. Brian Donner, who is just popped his head up here. He's now with us, and he made a really impactful point that opiates, the ones that you take home, should only be taken as needed. and not on any specific given schedule, because that given schedule is kind of what gets people hooked. Would you agree with that?
I think there's a significant correctness, if I may, for lack of better terms. I would agree with it, particularly in the early phases of defining what an individual, and particularly I think that's more applicable to the acute pain process,
right,
where, if something is not of a chronic nature and it's of a continuous nature, but it's of an intermittent duration and intolerance, or causing lack of function or sleep, or comes and goes, paroxysmal in nature, so to speak, then certainly the as needed medications are more appropriate. You start low, you work your way up, titrate. Some, philosophical or scientifically, they look at it from the standpoint, once it becomes more of a chronic condition that is non-remitting and not paroxysmal in nature, then there is some recommendation historically in classical teachings to go more to a scheduled basis.
Okay.
But I think, the literature, when we really look back at the literature relevant to take as needed, short-acting versus long-acting, there's really no clear-cut benefit to one or the other as far as outcome studies.
Okay.
Some argue that if you use short-actings, you're more likely to become addicted, versus long-actings don't have the peaks and troughs and the euphoria and the relaxation phases that the short-actings do with the long-actings, because of the slow onset and sustained release nature of it. So that's, not been defined, though, scientifically, as far as our literature and outcome studies, if I can.
Amy, you were nodding as I was asking the question. From your viewpoint as being an emergency room nurse, what would you say to that?
Well, I feel that people get on a schedule, especially geriatric patients. They are on a schedule. We take our medicine at this time, and if it's needed or not. So there's an addiction in older patients that we're seeing, because the doctor tells them to take the opiate at this time they might not be having the symptoms, it might be controlled, but because they're on that regular schedule. And in nursing, we're trained to kind of stay ahead of the patient's pain,
Right.
in the emergency department,
Right.
in an acute setting. So I feel that, it has its place, but continual dosing,
Yeah, that seems to be the problem.
yeah, it seems to be a problem.
Did you want to pipe in on that at all, Dr. Donner? Do you have any additional wisdom?
No, I think what they said, I agree completely, and I think Dr. Barrett sort of had a point there that maybe sometimes as needed may not be the right way to sort of term it, right? What's the pain cycle? Where are we now? So, but with the opiates being more appropriate for that acute pain than anything else, right?
Yeah.
So, and I think that all the panelists would agree. I think the problem is the escalation from there, right? So where's the stopping point of that? Where do we get to? Because it seems like it just continually goes up, right? When we need to be going the other way. So that would be my point.
Does anybody have any questions on any of this? Okay. Did you have another point, Dr. Barrett?
No.
Okay. We're going to get a little bit into what is how responsible are the doctors for this whole situation? And I'll start with Amy. How much do you think it's because of doctors not paying attention or not getting the instructions correctly, or just a lack of knowledge? Where do you think the problems really lie?
I don't believe that it's fully physician. We are trained to kind of assess our patients for pain and treat them accordingly. There was a pain scale added to one of our vital signs, and we are consistently treating and modifying that scale. Changes in how we we are treating people, we were increasing the doses of opiates because we wanted to have the patient's pain be controlled. And it's not something that you can, it's not like a physical, pain is not a physical thing that you can say, well, she doesn't feel that pain because she says it's a 10 and she's not writhing, but it might be a 10 for her. So
So the lack of ability to really have a firm grasp on
yes.
pain itself. Would you agree with that, Dr. Barrett?
I think it's education
Yeah.
as well.
Yeah, if I could add to Amy, because I would confer and agree, if I can clarify some of what she touched on and brought up was, and I think it's relevant to where we're at today. In the late 1990s, they looked at a lot of outcomes and studies in the hospital, and they defined that pain was undertreated. And in 2000, they identified the decade of pain from 2000 to 2010 was declared the decade of pain because pain was undertreated. They, as Amy had alluded to, they then declared it pain in the hospital setting and approach was the fifth vital sign, if I can add to that. So as part of a traditional assessment, it became a focus of care because nurses as well as care providers, i.e. physicians, were all identified that, hey, listen, if and there came out all these studies, and this was, backed predominantly by the medical system and the AMA, but it was really, if I could add to it, if I read always between the lines, and I think it's coming to enlighten here now as we're faced with the problems nationally that we're dealing with. This was really promoted by big pharmaceutica, to be quite honest.
Well, that's what, we're kind of going.
Yeah, so big pharmaceutica backed this and said, hey, listen, pain's undertreated. If you guys and all the reps flooded into our pain practices and the hospitals, and we were all then start to be forewarned of if you don't treat pain appropriately or adequately, you could be sued. They didn't really talk at that point about, well, if you prescribe too much or you're too aggressive and your patient goes out and becomes addicted then, or is it a major accident that you could be sued likewise or end up in the medical legal problems and issues. So this whole decade of pain unmasked itself and unraveled itself into what we see nowadays as a problem. And you see this with some of the pharmaceutical companies now coming into the legal ramifications of states and federal governments looking to come after them. And we see even the DA was involved, maybe potentially in unmasking the trail of the pills and the pharmaceuticals, the companies that backed it and supplied it and pushed it. That created a push within the physician's realms, both at the family practice level as well as the subspecialist level, in being more aggressive with treating pain, to come back to your answer. As a result, we were not trained historically nor classically. Most physicians, and I think, Brian, you could even agree to this, most of us were not trained in addiction medicine. So a lot of times what presented, and Amy alluded to this earlier, is pain comes in is a very complex, multifaceted problem, in the sense that it's biopsychosocial. It has to do with coping and nurturing and upbringing and many backgrounds, and it's a very subjective nature of what is reported. There's very little, I think this is what you're touching on, there's no good objective measures. We can't identify the pain complaint, and unfortunately, as being not trained nor skilled or formally classically taught in medical school nor postgraduate training, the problems that come with the report of pain and the potential luring for addiction and personality disorders and mood disorders, I think inadvertently a lot of physicians were treating mood disorders and anxiety disorders and depressive disorders and problems in the symptomatic complaint of pain with opiates as we were told to do.
Right.
And that really unraveled and unmasked a significant problem that we are now facing.
But it seems like you have a system where people say, oh, it's the system. Well, the system is comprised of these insurance companies, which have a say-so.
Yes.
You've got the big pharma, and their representatives out doing their thing.
Yes.
And so, I guess what I'm trying to get to is, where's the final responsibility of the doctor? Is it should, I would think it should always be towards patient care, patient safety. And is that system kind of overriding some of those issues for you? You're nodding, Amy. You want to jump in on that?
It feels like it is overridden, absolutely. A lot of patient care and patient safety.
Now, the other thing we get now into the dope sick is that once you're hooked, then there seems to be not a lot of good tools for the medical establishment to help get people. Well, first of all, just to identify, is somebody having, maybe you can jump in here on this, Dr. Barry, is somebody having withdrawal symptoms, which is the dope sick is the withdrawal from. Can you tell us a little bit about what some of those physical symptoms are?
Well, seeing this in our practice, what we've identified is either an abstinence or a withdrawal period. It begins with, depending on the agent that's being chronically either used or tolerant or abused. It starts with some nausea, abdominal complaints, vomiting, anxiety, mood swings, vital signs as far as actual physical identifiers. We look at increase in heart rate and tachypnea or increased respiratory drive and fast, rapid, shallow breathing, sweating. Diarrhea is fairly classic of an opiate withdrawal as well, or some of the symptoms at least. Insomnia, inability to sleep.
Dr. Donner in the articles made the point that it's kind of understood by the medical establishment that the withdrawal itself cannot cause death, but some of the things that, if you have a weakened system and you spend 5 days, hugging the toilet with vomiting, that could lead to some problems.
Yeah. Well, there's actually, to clarify that, there's a lot of literature out there, depending on what we call the comorbid condition, of the patient. If they have cardiac or pulmonary disorders, there's as high as a 10 to 11% mortality rate with acute withdrawal or abstinence period. So it's not a benign process in some individuals. Again, depending on their underlying medical condition.
Sure.
Yes.
Mandy, I saw you nodding a few times too. Have you dealt directly with people who are in the dope sick?
I have.
And what kind of
So symptoms or
symptoms, but then let's talk about some of the treatments, some of the things that actually can help them too.
So I feel that we have to take a very holistic approach, the overall whole body. So when you are weaning off or coming off or dope sick, we have to look at the whole aspect of crashing, because the body is severely crashing, and so we have to support the adrenals, the fight or flight, because the immune system. We have to support all aspects of the body, and we can do that, in alternative fashions. But if we're weaning off, we certainly have to wean off of the medication and not just cut it cold turkey, because all of the symptoms that do arise they can be lethal.
Yeah.
Also, I feel that the pain medications, induce an escape from the pain and the emotional correlation to why one is in pain. There's a lot of emotional manifestation that correlates with physical pain. And when you are medicating that for so many years, in a case I've worked with several individuals, but one woman, she's been on pain management since she was 15. She was a dancer. She was in chronic pain. She is now 43. She has no idea what it feels like to be off of a medication. And one thing that I have a hard time with too is when you're enrolled in pain management, they're so cautious and careful as to drug tests, and there's so many people I've met that, does this, because I work a lot with CBD, but I work overall with herbs, and everybody's different, so everybody's body needs
different attention physically and emotionally and nutritionally. But there's a lot of fear instilled from the medical world with weaning and coming off of pain management, because it's scary to not have that pain management when you're so used to it. But you're also afraid to partake in anything that might show up in your urine or your blood, because you're monitoring that, and you can't be on pain management or wean off if they see any type of anything in your urine or blood. So it says to me, do you really want a solution? Do you really want to help people come off of these pain medications, or do you want to just keep the cyclical catastrophe and epidemic happening? So hopefully
Amy,
that answers.
do you want to jump in and talk a little bit about how you've seen medical cannabis or the CBDs as a useful tool in coming off the dope sick?
I really feel that cannabis is a great tool, and I'm very thankful that it's now here in Pennsylvania. In the emergency department, we see many people daily with opiate abuse, dope sick, and I feel that this will be a tool to really relieve some of those addictions
I know
and
that
weaning.
part of the problem when people come into the emergency room is they may not want to say that they're in withdrawal. Do you see that a lot?
No one comes in and says I'm in withdrawal, really. They present with other things, and they either want more medication or they want help.
So in that seems to be a big problem then, when if somebody's hiding what the core problem is, and then you go, well, let's give you some more opiates.
Right. One thing that the state of Pennsylvania did institute was that we are now able to track the use of opiates. The physicians are able to, there's kind of a network that we can see who's prescribing, so that we can tell if they're out of their medications, if they're prescribed that, or if they're getting more medications from somewhere else. And we treat them symptomatically. We would monitor them, but I really feel that this is going to be a game changer for.
How when people are in that dope sick state, where they start to feel they're coming towards it and they run back and get onto the opiates, is that sickness, is that a big deterrent for people to try to get off or wean off? Do you see that as a major mental problem?
I believe they're fearful, and I'm sure they don't want to feel that way, but I also feel that they want resources. They don't want to feel that way. If we could kind of bridge the gap when they come to the emergency department and they are withdrawing and we treat them symptomatically, we should be able to also give them a support system to fall on, referrals that we can educate and so that they don't relapse. And we can't guarantee that. And we've sent people out the door 10 times. I've had somebody come in 10 times. Maybe that 11th time that I'm talking with them, that I'm giving them those numbers, that I'm sitting down and trying to address, and I will give them information about cannabis, and hopefully that they will take that opportunity.
Yeah. Did you want to address that at all, Dr. Barrett? How much of an incentive that sickness is to just staying on the opiates and not having to go through that?
I'm going to venture out to say that, and Kayla, my physician's assistant who works with me, Kayla, how long have you been doing this now? For how many years?
7.
7 years. I'm going to go out on a limb and say predominantly, I think it poses as the number one problem why patients don't want to come off of their opiates.
Sure. Yes, sir.
Are there any states where opiate withdrawal is an indication for medical marijuana?
I'm going to defer
Pennsylvania
to.
does not have that.
It's not here in
Not yet. So
Pennsylvania.
interestingly
Yeah.
enough, you just said that. So the advisory board, the State Medical Marijuana Advisory Board for Pennsylvania, has just voted on some new qualifying conditions. And one of the votes was for actually treatment of opioid withdrawal, really as one of the qualifying conditions. So this would be a tremendous step in the right direction. I can tell you this from other states that we've worked with, that classically has not been an option for patients, right? But Pennsylvania, it looks like it's going that way. It was voted on by the board, 8 in favor, 6 against, and 1 abstained. So we could be sort of on the precipice here.
Yeah, sure.
That's great.
Real quick too, a quick question point I want to bring up, Sven.
Sure.
I want to get Dr. Barrett and Kayla's insight on this. So one of the things that, and Amy and Andrea can attest to this, that we see now when I treat medical cannabis patients daily, is that obviously chronic pain is the most common diagnosis that we get, and many of our patients are on long-term opiates, and they're managed through a pain clinic. One of the things we're seeing relatively frequently now is some pain physicians are telling these patients, as soon as you get your medical marijuana card and you test positive for THC, you're done. We're cutting you off your medications. I have had some very interesting personal experiences talking to doctors about this. Some have been very open up front with me and, hey, listen, we'll work together in this weaning process. Others have said, I don't care what you say at all. Dr. Barrett, do you have any advice on the best way for both as doctors and as patients that we can approach this with a pain physician?
You know, Brian, and it's a very good point, because up till this more recent point that Pennsylvania enacted medical cannabis as an option for chronic pain, you know, and Kayla, you're aware of this as well. We were actually mandated by the states to be monitoring for concurrent, what we call substance misuse abuse, of which, you know, that would include, you know, traditionally up to that point would have been marijuana, cocaine, barbiturates, you know, you name it, any substance of illicit, illegal nature. And if we were defined by the DEA or state investigators to have come in, seized our records and reviewed, and we had drug screened these patients, and we had identified that they had concurrent other substance abuse or substance of misuse of illicit nature, that we would be, from a medical legal standpoint, we would come under scrutiny with the potential for aiding or abating, and it was essentially illegal from a medical standpoint. So in our classic, up to this point, training and process of chronic pain management, and I think you even spoke of this, is if they even take CBD and they get screened for this,
Right.
they're going to be kicked out of their pain clinic.
Yeah,
And
a lot of fear.
unfortunately, you know, there's not a consensual agreement. I think even in our practice that we have, you know, I think I'm certainly more willing to work with this with some commonalities of the goals in mind, in lowering opiate dose, if not abstaining or weaning them off them completely as either a step out or a wean process, or treating them with this from a medical management from a chronic pain standpoint. But to answer that, Brian, it's very difficult, because I still think the spillover is in our classic world of pain management that we're working with in the confines of still is most of the doctors are looking at and say, well, you can't be on both. You choose one or the other. And we've actually talked about this privately, I think, Brian, and I spoke with some of your physicians as to the goals. I think the goal should be is if we're instituting or implementing medical cannabis as a treatment for chronic pain, then the goal should be is to lower the dosage of morphine milliequivalents per day of the opiate. And by all intent purposes, the preliminary initial studies that are out there really show that's been the case historically. Not only does it lower the dosing, but when they look at some of the states where medical marijuana has been initiated, actual death overdoses related to prescription medications have come down significantly. Most of the states that have identified this, it's at least around 25% reduction in pain pill, not just heroin. If you threw in heroin, it's higher than that even. It's upwards of 40% reduction. So there's some literature that's going to drive this and research, I think, that will gain it mainstream more acceptance. Right now, we're in a crossover gray zone as to how we handle this, I think, and who is willing to embrace the weaning or the transition with the concurrent medical use of cannabis in concomitant use with the opiates. I think it's a mistake to put to the patient to define them at the front end of introduction of medical cannabis that the goal is to eliminate them off of opiates. It creates too much angst, anxiety to the patient. They're more likely to not do a step out. I think it's a disservice to the individual. It requires, if the goal is to wean them off or get them off of the opiates, I think you need, as a provider, to offer them the understanding of the supports that are out there. And again, it's a strategy. It's just not a medication, if I can, because I'm sitting along two sides of providers that we use, concurrently or concomitantly in trying to wean.
Well, we've done a little bit of a scratching of the surface of the problems. So I'd like to start talking about some of the solutions. I'm sure that's what a lot of people are here for. And again, with my background in the holistic health world, and then working with a lot of really classy people, you can struggle a little bit then. You too, Joseph. That one of the key things is that the person who is trying to wean off still has an underlying pain problem, perhaps, or whatever it was that sent them to the opioids in the first place. That has to be addressed as well as the weaning off. So you've got a twofold situation. Joss, I'm going to let you jump in here and talk about when somebody wants to tackle this problem. They've got the opiates and they've got this other thing. How important is it that they take on an attitude of, this is my responsibility and I am the only one that can get out of this? Or what's the role of that in trying to put together a whole plan to address all the issues?
Well, in my experience working with people, it's been really interesting to get them to the place of recognizing that there is an underlying spiritual issue that has manifested itself physically. And that when we have experiences in our life and they are not dealt with, we have broken hearts. And human beings are very tender and breakable people. And to acknowledge that something that should not have impaired another person has impaired you and stunted you or kept you stuck in some way, stuck in an event, stuck in an emotion, stuck in a belief system or a thought form or an opinion, or someone said something to you 25 years ago and it's still running your life. It's important that they recognize that that thing has a hold over them and that they need to acknowledge that they're still running off of a program that no longer works in their computer system. Getting them to that place can sometimes take hours of listening, because for a lot of people, they really need somebody to hear their story. And they really need somebody to listen with an open heart and hold the space of possibility. I meet lots of people that are in pain, but pain has a lot of different forms. It's not just physical pain. It's spiritual pain, emotional pain, psychological pain. And you have to give people the space to talk about all of them.
In fact, in the articles that I wrote for World Magazine, you worked with one of the mothers, and she told me this, that it was only when Jasa was able to help her understand that the physical pain was actually caused by that emotional pain. And then you gave her some tools to help unlock that emotional pain, and what do you know, a lot of that physical pain then went away. Can you talk a little bit about that process?
The process is really about telling the truth. And telling the truth regardless of the label that it's attached to, whether the label is mother or friend or spouse or child, and giving people an opportunity to say what's really hurting their heart. My experience is that most people are walking around, and many of them have a large part of them that really doesn't want to be here because of the pain that they're in. And when you talk to them and give them the opportunity to allow for the parts that want to die, so that the parts that want to live can survive and thrive, then you have a starting point. But if they are captured in the pain and captured in the darkness and feeling trapped by that, there's nowhere for them to go. So you give them the option of making a choice. and holding the space that whatever they choose, you will love them regardless of how it looks. And giving people an option to look at things from an expanded perspective. And I work with spirit. I work from a non-traditional point of view in a lot of different things, but giving people an option to say, I want this or I don't want that. I like this or I don't like that, about their own life and about themselves, about their upbringing, about their story. We are story beings, and the story has to unfold. And in the unfolding of the story, we have to look at what's really true. And people who are in a lot of emotional or psychological or spiritual pain, they really are not real good at telling the truth about the source of the pain, because acknowledging that truth may mean acknowledging that the one person that they are dependent on is the person that is the source of so much discontent in their lives. And it's really important to give them the space to say that, and that they know you're not going to judge them for that.
Mandy, do you want to jump in and talk about the need for having a whole set of tools, a well-rounded toolbox, as it were?
Sure. I think I'm loud enough. I'll be way too loud.
Yeah, we were already shushed for the last session.
Yeah, we gotta yell that, right? Okay, yeah. So obviously, I think it's necessary to take a holistic approach. So similar to what Jasa is speaking, we have to get to the root or the roots of where trauma, pain are coming from. Oftentimes, we don't even know what that is. You know, I used an example lately about, you know, even going through puberty. It's pretty scary. We don't really realize that, but as we get older, we push that down. We push it down because it's scary. We don't know what to expect. We've heard about it. Oh my gosh, what's going on? But we carry that, and it creates shame. And we're carrying the shame, but we don't want to think about it, and we don't want to remember it. So many years later, it might manifest into, or it will manifest into pain, or hormonal imbalances, or infertility. But why infertility? Because when you went through puberty, you manifested a lot of fear and a lot of shame. So I think that, or I know that, you know, each person is also different. So there's no toolbox that fits everybody the same way. There's no doses of anything that fits everybody the same way. So I think it's important to have a team, and to also have your team be respectful and understanding of all aspects of healing. And I think alternative and medical, there's a lot of detachment. And the beautiful thing about the cannabis industry coming into play is that we all can support that and see the benefits of it. But we also have to, sorry if I'm all over the place, but we also really have to support ourselves physically while we work through these emotional traumas. Because I don't believe in crashing. I don't believe in this concept of healing crisis. Because when we're in a crisis, we're crashing. So how do we heal if we're constantly crashing? So I think it's very important in the toolbox to have the emotional and the psychic support, the spiritual support. I think it's very important to monitor what nutrients and medications are being used. I think the patient needs to feel safe and needs to have a relationship and not a revolving door. I think that's hard in the medical world because there are so many cases where we're just a number. I mean, even speaking in the office, how many patients you see, you know, I think that how could you be compassionate and empathetic and devoted to all of those people without being burnt out and worn out and just, you know, and then when you try to share a holistic or alternative healer or healers with your doctor, you're petrified or scared because you don't know how they're going to respond. I have myself had a challenging time with a lot of doctors, you know, some, not all, you know, prior to the medical cannabis as well, but you know, even accepting or respecting or not poo-pooing, or, you know, and so that doesn't give the patient support at all or any hope, and there's a lot of shame, and so it's again the cyclical cycle. So so the toolbox, it can't just be, I don't believe it's one thing, you know. I believe there's many components, even, you know, breath work and meditation and yoga, and those could be very weird or strange to a lot of people, so they run from them. So I think it's very important to take the time and to embrace people and let them know that they're not alone and that it's not crazy just because you don't know what it's about or it sounds woo-woo or, I mean, just using terms, but I think people just crave embrace and like Jocelyn was saying, crave to be, to crave trust and compassion and so that they can open up because we have to spill it in order to fill ourselves back up with health and happiness.
It's a level of unconditionality that people are looking for, that no matter what they're experiencing, how they're presenting themselves, what their background is, that someone believes that they have the capacity for being well and whole. And a lot of people that are experiencing brokenness don't experience anything in their outer world that says you're going to be okay. And that my belief, you are born into perfection and you have a birthright to experience that. Whatever perfection looks like to you, it doesn't have to match anyone else's opinion or experiences. And a lot of times, people's idea of what their perfect life is going to look like is based on what other people's stories are. You have to help them see what their story is. And in doing that, it gives them an opportunity to take a deep breath. I can't tell you how many times I've had a client say something like, well, my mother told me that was true, or my father, or I had this experience. And you have to ask them, whose voice is in there telling you these things that you're still acting from, and it hasn't been true for 17 years or longer, but you still act as if it is.
So we're coming up towards the end of our time here. The room is empty afterwards, so I guess we can run a couple minutes longer. Is there any questions anybody has for any of the panel on any of the topics we've got here today? Okay, well, I'll ask one more.
The gentleman back there in the yellow.
Oh, he did? Okay, I'm sorry, I didn't see it.
Thank you. I was just wondering if there was any contact information or the availability of that would be for support systems for individuals that need.
Contact information on support systems. Amy, I think you're probably good for this one.
I'm sorry, in what form? In withdrawals or?
So with this being so new to the area, right?
You're talking about the cannabis specifically?
Yes.
Okay.
If people are still starving for information, and I guess what's the best places to search for that?
Well, I don't.
Websites or?
Your organization.
I think
yeah.
we're pretty. We're the ground. We're it. We're setting this. We're trying to set the standard and the groundwork. So if you would have any questions, I feel like that you would want to come to us.
Yeah, compassionate certification centers.
And there are support systems as well nationally. I mean, obviously, I agree with Amy. We're partial to our shop. Right? It's one of the things that we do is we really try to take care of people. And it's not just about getting your certification card, right? It's about the treatment program and everything. But organizations like Americans for Safe Access, there's a bunch out there that can really help. The problem, and sometimes what you get, is that we've all been there. If you Google search medical marijuana information, CBD information, you're just thrown with this slew of information. How do you sort through this? What's appropriate? What's not? That's very difficult for even people like us who are very well trained in this, right? So I think that's whenever hopefully people can lean on a provider to help guide them to that additional support system as well. But they are out there. It's just sometimes you got to get through the weeds to find them.
Donald?
Yeah. So I guess my question is more of a medical for the medical guys here, the doctors. So I've had a little bit of experience in the California cannabis industry, and my patients a lot of them were actually coming off of opioid addiction. And the concentrate that we were giving them was actually helping them get through their treatments, and they would need less of what they were getting. One of the things I was kind of hoping to come here and maybe find out and ask a question about was, are you guys familiar with exactly why cannabis is doing this for people? Like, do you know exactly which receptors it is that it's hitting, or is it because it's hitting the same receptors as these opioids and replacing? Like, I'm not sure exactly why we're having such a dramatic effect on these kinds of patients. So, do you guys have anything that maybe you can, do you have any information on that? Because that wasn't something that I studied, it was something that we just came across that just ended up being a huge thing, you know?
So I think there's a few things in this, and sorry, and Randy, you might want to get into this as well, but I think when you look at the treatment of chronic pain, right? What medical marijuana offers is the ability to do two things, which I think is fantastic. Number one, it's going to potentially control those symptoms, right? So the symptoms of your experiencing the pain, it's going to be able to provide analgesia. The other thing, depending on your disease process or entity that we're treating, is that medical cannabis could actually go to the root of the cause, right? The problem. So you're not just treating the symptoms, right? You're treating the actual cause of it. When you look at something with respect to the opiates, what medical marijuana offers is a alternative option to treat somebody's pain, while at the same time minimizing some of the effects of opiate withdrawal and toxicity, right? But not toxicity, withdrawal symptoms more.
Right.
So when you can put both of those properties into one medication, I think that makes it an ideal medication. There's also been some studies out there that have shown that patients, and Dr. Bear will be able to comment on this even more, but that patients who are on medical marijuana and they're also on opiates, they require a lower dose of opiates. Right, exactly, and they can go longer without these, right, but still experience the same analgesic effect. So I think there's some biochemical probably communication between the endocannabinoid, your opiates, and your mu receptors, all that. So
That's exactly what I'm asking about.
Yeah, you know what, Brian, now we're getting into breaking it down on the receptor model, more of a biophysical based receptor model, and we know certainly that it's, you know, some of these receptors are in the brain, and again, as you touched on, Brian, some of the side effects actually of the cannabis or the cannabinoids is what minimizes some of those withdrawal abstinence symptoms that we identify: the nausea, vomiting, the insomnia, the anxiety. So depending on the type of medical cannabis that is utilized will depend on whether or not it has stronger properties towards the treatment of those withdrawal symptoms. Now, but as far as from what I've been able to review and understand, at least at my level, you know, the research continues on as far as the definition of the receptors. That there's good body of literature that I've reviewed personally coming into this that identifies that it minimizes what we call opioid hyperalgesia, and which then likewise is minimizing the degree of tolerance, particularly relevant to morphine when they look at it in combination with morphine, particularly. So, you know, I don't think the scientific component of that is quite there yet. I think, Brian, you know, safe to say, I think a lot of as medical cannabis and its ability to be researched, hopefully in the future as it comes to more of a forefront in the research background, they'll identify some of the biochemical components and the receptors and levels and that interface and how that works.
We're still trying to figure out now even how all these cannabinoids themselves work together, right? So then when you take systems outside of that, right, it becomes very complicated, very complex, and I think Dr. Barrett's right. We scratch the surface on this, we see the potential, and we're starting to understand it, but there's still a lot of doors we have to open to really have a better feeling on this, right?
Now, I guess my second question that I had, do you mind if I ask another one?
Well, you know what, we're getting a little long on time. Let me take one more question in the denim jacket there.
Will we cancel out a patient that's been taking medication for years? I'm talking about over 15 pills. Both of my grandmothers are extremely sick, and I wanted to know how they would become a medical cannabis candidate with so many drugs that they take, and opioids, of course, is one of them.
You talk to this guy right here.
Absolutely. And that's something that, you know, literally what our organization specializes in. And there's we have some tools at our disposal. Yeah, even downstairs, there's one of our vendors where we're able to take people. We know that medical marijuana generally is processed through the liver, through certain biochemical systems. We know that other drugs work on these systems as well, and what we're able to do then is figure out these interactions. How can things work? Is this gonna be safe if we put somebody on this medication, right? So it's really what we call polypharmacy, I would say, more than anything else in managing that. And again, at that point, what you need is you need the tools and the resources to be able to do it, right? Sometimes the problem comes whenever people are on medications that we can't just take them off of immediately, right? Or that maybe it's a medication that Dr. Barrett and I aren't experienced in using, right? That somebody else was put on. So how do you then start to manage that? And that gets very, very complicated. But the bottom line answer is you take your time, you put your nose in the books, you start talking to people who know stuff, and you do it on a case-by-case basis.
I'm going to say let's go ahead and wrap it up, and then you guys can ask questions personally if you can. You guys all want to just give your contact information or where you be or how people can get in touch with you, Mandy?
Sure. I'm local in Pittsburgh, but I do see clients remotely in long distance. I'm located in Lawrenceville.
Website.
Okay, I'm like, do you want my phone or my website is, I know, I'm just like, it's been a really awesome long few days here. So my website is holistic with an H, HOLISTIC, health with Mandy, MANDI.com. So it's all spelled out, holistichealthwithmandy.com. I have some cards here too, with my phone number too. Yeah. So.
Okay. Hey, Amy, how can people reach you?
Well, I work for Compassionate Certification Centers. We have a 1-800 number, but they can reach me at my email also, Amy@Compassionate Certification Center.
And spell your first name for me.
AIMEE.
Through an extra, it's Amy with an I too. Dr. Barrett, how can people reach you?
Well, our practice is North Pittsburgh Pain Physicians, and we have offices in Natrona, Katanning, Clarion, and Punxsutawney. Website, I guess, and we're with Compassionate Care Certification Centers as well in our office and working concomitantly with them. So there's a website, the NP3, Marlena Kayla. .com, yeah.
and Jocelyn, how can people find you?
You can reach me through my website. It's jossatthemystic.com. You can also reach me through the Foundation for Shamanic Studies. They have a referral area, and I am one of the people listed in Pennsylvania.
And all of you are going to hang around so we
How do you
can.
spell Jocelyn?
Oh, it's spelled Jocelyn.
JASA.
We're being visited by aliens.
I know. Whoa, it's very mystical.
Shamanic study.
That's all this shamanic bringing in. What kind of spirits are bringing in?
Good vibes.
So everybody will mingle for a few minutes, and the room is not being used after this. So thank you very much for your
Thank you, guys.
attention. Make sure you pick up a copy of Dispense magazine.